I've been asked to talk a little bit about some of the work I've done with a lot of friends and colleagues over the last few years, and kind of just synthesize some thoughts really about cancer in the time of COVID and conflict, which is a slightly unusual title. Let me maybe just start by giving a bit of background of who we are in the sense of the sort of groups that I'm involved with, because it kind of will explain a little bit why I'm interested in global cancer and also this issue of conflict ecosystems. Half of my life is really in this area, which is sort of global oncology group in the Institute of Cancer Policy. And it's fantastic. We've got about 82 faculty now, spread around 52 countries. It's grown over the last 12 years into being a very multi-dimensional program. And it extends really from sort of clinical trials, implementation research. We're working on at the moment in India, all the way to sort of really fundamental discussions and discourse around value and affordability, with great friends like Chris Booth at Kingston University in Ontario and C.S. Pramish at Tata Memorial. But if you go on the website, you'll see a lot more detail. Thematically today, I'm going to really focus a lot about the issues about value, affordability, and universal health coverage, and also integrate that into our thinking and insights around global cancer services and systems. So that's one half of my life. The other half of my life is helping convene the Conflict and Health Research Group, which is quite an unusual organisation which sits within security studies at King's College London. It's a huge faculty. We've got nearly 102 people now. It's really big because it spans everything from people working in security studies and IR, all the way through to clinical medicine, in other words, the clinical practice of medicine within humanitarians and conflict settings. We've got a very big civil security interface, and by security, I broadly mean the civilian sector, the military sector, and the broader security sector as well, because in many countries around the world, the security services, and by and large, we're talking the military here, have a very large role in delivering healthcare services into populations. We're particularly well known for our work in the Middle East, but increasingly we're doing a lot more work in sub-Saharan Africa and also in some of the narco states in Latin America. So that's the other half of my life. Cancer in context. I'm going to start by really sort of saying two slides because they're kind of really important points to put across before I sort of dive into the meat of things. And that's the first to say this, that, you know, generally speaking, we think of cancer as a distinct disease entity, but actually, of course, cancer is just simply one disease within our overall health systems. And the Institute of Medicine made a statement many years ago, and it said, cancer exposes all the strengths and weaknesses of our health systems. And if you think about, you know, our health systems as a Mount Everest, really cancer and cancer control and good outcomes represents the kind of pinnacle of cancer care and control. And of course, the great paradigm of precision or personalized cancer medicine, I would almost argue, is the small Swiss flag right on the top of Everest, or indeed, you know, on the Hillary steps just going up. It really is the pinnacle. Everything else underneath has to work really well for you to get the best outcomes if you're delivering that sort of high-end cancer care. The other thing to say is that achieving the best, the most affordable, and the most equitable outcomes is a product of complex adaptive systems. In other words, regardless of whatever site-specific cancer you're looking at or whatever modality you're looking at, the outcome is a product of a lot of bits of the system working together. And if any aspect of that system is weak, that pulls the outcomes down. And to give you some idea, this is just the 5-year survival from Eurocare, a big study that's been done across Europe, looking at site-specific cancers. And those ranges you see for the site-specific cancers are between the best and the worst performing European countries. Extraordinary differences. 28% survival difference in testicular cancer, 32% difference in rectal cancer. Now, of course, since the 1950s and post-World War, everything's improved. I mean, the earliest data we have is from this paper in New England Journal of Medicine in 1943. So you can see outcomes have gone up. But what we're seeing in many countries is we're seeing a real divergence in outcomes between the best performing and the worst performing. And the worrying thing is a lot of the data indicates at the moment this is getting worse pre-pandemic. So what the pandemic is going to do to it, and I'll come on to that a little bit later, is an unknown at the moment. But this is the reality at the moment. The outcomes are incredibly variable around the world. What about conflict ecosystems? between about 1.5 to 2.5 billion people around the world live in a country or a region which is considered to be in conflict. That can be everything from political insecurity to full-scale interstate war. When you look at this, the typologies, of course, of conflict ecosystems are extraordinarily varied here. So, of course, you'll all be very familiar with the current wars still going on, and most of them, fortunately, petering out in the Middle East now. But of course, we've still got many, many conflicts still going on within sub-Saharan Africa. The most prominent at the moment is a massive civil war going on in Ethiopia. But of course, let's not forget in Latin America and South America, the narco wars that Mexico have experienced have been the second highest cause of conflict-related mortality in the world. What this means, of course, is that the ecosystems in which our cancer patients are living are very different if you're living in a conflict ecosystem. And of course, what we're seeing now, of course, is a lot of conflict is impacting transitioned countries. So these are countries that have gone through the epidemiological and demographic transition. They've already got high burdens of cancer. And we're seeing that now as a major health issue. It's not just infectious disease and reproductive medicine issues anymore. And the impact, of course, is on populations from official UNHCR refugees all the way through to internally displaced populations. So as an ecosystem for thinking about cancer control, it's very unique and it covers a large proportion of the world's population. You also have to think about this, and this is where it kind of interdigitates with the discussion around COVID-19, is complex emergences and conflict sit hand in hand with changes in our disease ecosystem. And there's a marvelous paper here called Disease and Development in Africa by Hughes and Hunter. It was from 1970 in Social Science and Medicine. If you haven't read this paper, read it. It's absolutely superb. And it talks about how development basically alters the shape of our disease ecosystems. And the point I want to make here is, of course, conflict shapes a lot of disease exposures. And ourselves and other individuals have done a lot of work in this. There's a very nice paper here by Vinkim Neugen, a friend of mine now at Geneva Institute, who talks about Ebola and violence in the Democratic Republic of Congo. People have forgotten Ebola. It's incredible because really when you think about the West African and the DRC outbreaks, it's a massively dangerous pathogen. And he talks very nicely about how the conflict and disease ecosystems are shaped by human endeavors. So that's just to put that out there. One of the problems I think we have now with the COVID-19 pandemic is it's made people very, very acutely aware that, of course, infectious diseases, epidemics and pandemics are a significant issue for the human population, and they're not going away. In fact, they are actually increasing. We've had about 1,500 epidemics across all these countries in the last 2 decades. Basically, you're looking at a big size epidemic every 2 to 4 years. So the problem at the moment within the infectious disease world, of course, is as the communities get globalized, as we see development occurring, as we see closer interaction between the animal, wildlife world, husbandry and human beings, we are going to see more and more infectious diseases jumping across this species barrier. So for the cancer community, the new reality going forward is going to be epidemics and pandemics over the next 20 to 30 years. This is just a reality. What conflict does is it drives this even more. It's a catalysis for even more viral mixing, for example, and even more transmission into the human populations. So how will conflict and COVID shape our cancer systems? Well, the first thing to say is I think the experience of COVID-19 has already changed our health landscapes. Some of these changes will be permanent, some of them will be temporary. There's a huge amount of work on this, and I haven't got really time to go through today, but if you go into this website, the COVID Cancer Taskforce.org website, you'll see a lot of colleagues of mine from everywhere from Japan, Malaysia, Colombia, India, all the way across the world to sort of Kenya's, Zambia's, etc., who we pulled together, who published an awful lot of their work. It's really interesting because it shows the diversity of thinking, and also it shows you the diversity of how people have had to adapt to the COVID-19 pandemic in terms of cancer care. I put this, I know you can speak Arabic, I put this up slightly tongue-in-cheek. This is actually a Taliban SARS-CoV-2 testing post. Slightly disturbingly, they've got sort of PK machine guns on the testing table there, and a couple of guys with AK-47s. I mean, goodness knows what happened if you'd have tested positive at this station. But the point being is, everywhere in the world, we have seen ecosystems, health ecosystems, having to adapt to the pandemic. And by the way, it is not over. The estimates are we're going to see this rolling well into 2022, maybe even into 2023. And I think this is going to shape the landscape in ways that we simply don't quite understand yet. When it comes to conflict and how this kind of fits together with it, I'm just going to use one example here, and it's some example that we collaborated with a good friend of mine from Pakistan, Asim Yosef, to look at cancer care between Afghanistan and Pakistan there, which is on that eastern border. And what we saw, of course, when we looked at the number of cancer patients from Afghanistan in Pakistan, was incredible migration routes. So the darker the color is, the more patients are migrating to the cancer center in Pakistan. And what you see, of course, is a reflection that the therapeutic geographies of cancer patients all over the world are changing. They're moving across borders. So we call this kind of post-Westphalian cancer care. We think very much of cancer care as national cancer control plans, but the reality is conflict and other complex emergencies push people vast distances between regions in their countries, but also increasingly are pushing people into other countries to access their cancer care. What you see, of course, is the impact of non-pharmacological measures, and the way we've been looking at pandemic control, of course, has been layered on top of the conflict. So when COVID-19 came in, of course, with the Afghan conflict, it also altered the pathways. And they altered the pathways because of how people were able to access Pakistan, whether it was through Spin Bolduc or one of the other access routes. So you see rapid power changes occurring in terms of the dynamics of cancer patients. And it's what we call the Heraclitus problem with policy. And Heraclitus was a philosopher that basically said, you can never step into the same river twice. You know, think about it. You can never, the water is always flowing. So every time you step into the river, it is different water flowing past you. If the systems are this complicated, having policy which keeps up with this sort of dynamic complexity is incredibly difficult, particularly when you're thinking about universal health coverage. In other words, how do you socially protect patients from catastrophic expenditure? We also know, of course, there's profound system disruptions and downstream impacts on mortality. And both conflict and indeed the COVID-19 pandemic together have really, really illuminated this. And let me put three major papers together to give you just some sense of what I'm trying to get at here. The first is that delays in diagnosis lead to worse outcomes. This is work that was led by Ajay Agarwal in my institution with a number of friends and colleagues at London School of Hygiene and Tropical Medicine. In this sort of model, when you apply it to other countries, you see very different impacts in terms of delays in diagnosis and downstream mortality. We also know delays in treatment radically affect your cancer site-specific mortality as well. And this is terrific work that Tim Hanna and Chris Booth led. Again, we collaborated with them on this. They led this, and it was published in the BMJ. And the mortality increases for delays, for example, in breast cancer surgery, are quite significant. Then further on from that, some work that just came out very recently from the Lancet Oncology from COVID surgery, looking at the effect of COVID-19 pandemic lockdowns on planned cancer surgery for 15 tumor types across 61 countries, found this. If you look at the time in full lockdown there, so this is the COVID stringency measure. This is the amount of time that populations essentially were locked down in their homes here. And then you look at the time from diagnosis to operation up here, 5, 10, 15 weeks. You can basically see the stronger the lockdown is, the greater the delay is to obtain your surgery. Now, the reality is about 1 in 8, 1 in 9 patients in many of these countries never got their cancer surgery full stop. But many of them that were in really high lockdown countries had delays, which you can then see are going to have massive impacts on their mortality. Now, this is going to be a truism in high-income countries, and it's also going to be a truism in emerging economies as well. And this is a really, really substantial problem, because what it's taught us about the COVID-19 pandemic is non-pharmaceutical interventions have significant consequences on health systems. If you don't keep the health system open, then this is the sort of thing that happens to cancer. And of course, it's a truism for other forms of disease as well. We've seen increases in mental health, we've seen real significant problems in reproductive health, etc. What else has happened and what else is seeing around the world? Well, both in terms of conflict and post-pandemic period, it's really catalyzed a new wave of cancer workforce migration. I'd probably argue that workforce for cancer control is probably the single biggest issue we are going to be faced with over the next decade. It's simply insufficient to deliver the levels of care needed to have good outcomes. This is an excellent book. It's written by Omar Dawachi and talks about the experiences of doctors in Iraq and the reasons for them leaving and moving to other countries. He's actually a social anthropologist. It's a really, really nice read. If you really want to understand why doctors leave conflict countries, why some of them choose to stay, this is a book I would really thoroughly recommend to you. And I'm saying this without getting any royalties out of this, by the way, just to let you know. It's an excellent book, though. The pre-COVID-19 situation was migration of workforce was high, and there was a significant unmet need in many middle-income countries. We already knew that. And basically, the OECD estimates were in the pre-COVID period, between 42 and 88% of trained cancer surgeons were migrating to high-income settings. Now, this is catastrophic because the gap analysis that we concluded with Michael Barton this year, just for surgery alone, is somewhere between 34 and 86% if you look at individual countries around the world. And we still don't know what the levels of migrations are going to be over 21 into 22, but the qualitative assessments that the World Bank have done indicated that something between 20 and 60% of trained healthcare professionals are currently looking to leave their country that they're currently working in, mainly due to the economic crisis that the pandemic has engendered. So this is a massive, massive problem. And just to make the point, it's not just about radiotherapy. I think the problem with cancer is we have multiple needs across clinical oncology, radiation, surgery, medical oncology. And I could sit here and just show you graph after graph after graph of unmet need, and they all superimpose on top of each other. So we have a multi-dimensional workforce issue here that I think is going to be the most significant challenge going forward. Turning to the economic impacts as well, because this interdigitates with the issues of workforce. First of course, it's a driver of workforce migration. And secondly, the economic strength of a country determines its ability to pay proper wages for public sector healthcare workforce. There's a paper that's come out, and it's a really detailed piece of work, but again, I recommend you read it. It's by Miguel and Mubarak from the National Bureau of Economic Research, looking at what non-pharmaceutical interventions have actually done in terms of impacting the global economy. There was a belief, and then it's interesting because some of this is true and some of it is extrapolation, that COVID control measures would, in terms of reducing mortality, would save the world around 7.9 trillion. This became the really big economic figure for shutting societies down. The problem was, a lot of this was based on the economic modeling for basis in high-income countries. This new paper that's come out by Miguel and Mubarak basically shows that actually the impact of non-pharmaceutical inventions in many countries is going to be devastating. And this is the problem. It's shut down healthcare and it's shut down economies. And broadly what that means, of course, is that economic consequences on cancer are going to be very substantial. In many parts of the world, in low middle income countries, we're going to see economic downturns. What we know from this is, and this is again work we did with Refat Atun, is that this will reduce the coverage for universal health coverage, and you will see mortality from cancer inevitably rise. That'll be due to a lack of public health protection. That'll be due to issues around social determinants, increasing poverty, but it'll also be due to issues of the provision of care as well. What I'm hearing at the moment is that, and this is coming from the World Bank and the IMF, is countries are going to need to do a lot more with a lot less. Number two is we're going to have to find ways of integrating cancer care in with other models of care. So the idea that cancer is going to be planned separately from, let's say, maternal or reproductive health is just gone now. And thirdly, the constant challenge is what we're doing affordable? Not is it cost effective, but is it actually affordable when we look at the budget impacts? And that is those are the three big messages coming down to countries at the moment. So I want to go into sort of the last 4 slides now and say, well, what do I think needs to change? This is sort of thoughts of Sullivan, really. I'm particularly concerned about the over-focus on global health security at the moment. And this is strange coming from somebody who, half my life is global health security, but just trying to strengthen health systems to be resilient to pandemics is a surefire way of ruining absolutely everything else. And I would argue very strongly that good cancer control is a reflection of good health system strengthening, and good health system strengthening will equal good global health security. But if you read a lot of the documents coming out now, if you read a lot of what's coming out from either the G20, the G7, or indeed WHO, it's quite confused about where the money is going to go for the future of health systems strengthening, and indeed where it's going to be assigned. And there's a real danger here of hypothecation into a very, very narrow area, which again may benefit high-income countries, but doesn't do much to strengthen overall health systems or cancer control. The second thing to say is health intelligence is still garbage. It's abysmal. It's abysmal. And I would argue in a lot of countries, cancer intelligence is still abysmal. In just basic parameters, incidence, prevalence, mortality. There's a tendency I find in the West to fund modeling. Enormous amounts of money goes into the global burden of disease estimates, etc. My question is, why on earth aren't we strengthening health systems and data collection systems at the ground level? We've argued very strongly in these papers, which again, I'm very happy to circulate these slides, that you actually need to develop not just data capture systems, but good intelligence as well. And by intelligence, we mean actionable data in a timely manner that policymakers can use. In cancer control, registries are a first step, but really what you're looking at is site-specific audits to really help evolve systems, develop new models of care, and develop better systems overall. The third thing to say is that, and you've heard me say this a little bit earlier, is cancer control is no longer just national. We are really in a new post-Westphalian therapeutic geographies, patients moving across borders. There has to be an awful lot more thinking around this about how we're going to provide the social protection for patients receiving care, and indeed how we care for those patients. Where I'm sitting in the UK, and some of you may be sitting here as well, we're seeing a lot more migration across Europe even now, particularly when we're dealing with specific orphan areas. We're seeing a lot of children now moving from Central and Eastern Europe to high income countries to access care. But this is going to become a new reality, that people will move across borders more and more. So there's a question here about how do we actually build this in? And of course, within the insecurity and the conflict ecosystems, how do we build in cancer control into what we consider to be often non-traditional players? I speak an awful lot to security sector militaries around the world that have enormous power in delivering healthcare services. There's a very nice paper here by Martin Brinkman and Simon Horn about this, which is on security sector health systems and global health. They're equally as important as the public sector providers often in delivering good cancer care. And of course, the final group, which we really haven't engaged very well so far, are the humanitarian organizations, the ICRC, the MSFs, etc. So I guess it finishes off with this and says, look, one of the things that still bothers me enormously is, we have a Western paradigm about cancer control. It's dominated by high-cost biopharmaceutical paradigm, either for care or research. A lot of this thinking is simply not relevant to patient care in many of these therapeutic geographies I've talked about. And this is something we wrote, a few years ago now, which I still think is timely, is that cancer patients need better care, not just more technology. And that's not being anti-technological. I'm a really, really strong advocate of technology, but technology embedded within health services and systems, within cancer services and cancer systems. Technology only delivers the value that the services and the systems allow it to deliver. So there's lots of excellent technology, but it's often not trialed properly in those particular ecosystems. And that's finally just to say, this is just a very, very quick canter through enormous amount of work with some fantastic colleagues I've worked with over the years here in many, many different organizations. and particularly just to people like Ajay Agarwal, my friends in SMU, Eric Bing, Grosswick Parham in Zambia, Chris Booth in Kingston, Ian, of course, who's on the call today, and Pramish, but lots and lots of other individuals. So thank you all very much indeed for listening, and back to you.
Thank you so much, Richard. So I would appreciate if you could turn your cameras back on. So looking forward to your questions. Feel free to raise hands. Richard, I would like to start with one question. Very interesting statistics and extremely troubling in terms of practitioners, physicians exiting conflict zone. And obviously what we have in the NHS now in the UK with cancer care is also quite a disaster. It looks like we're facing years of delays. And at least when I went to college, it was quite popular to see medical school students who were dreaming about going into developing countries. You know, this was kind of tick box on the agenda to experience the world, to get practice. Now with such demand in the Western world, how is this changing? What are doctors from the West still interested in going, or there's so much demand here, or they're so frustrated here that they want to go to developing world? What's going on with that kind of dynamic?
I'm going to say something up front, slightly controversial maybe, but I think a lot of the models we have in the West feel rather colonial, to be honest. It's, you know, it's kind of parachuting people into countries and doing a few workshops and then out you go again. I guess there's a sort of new model on it, but it's entirely dependent on funding, which is how do you help your friends in other countries? And I do mean their friends. This isn't about going in, imposing yourself, but how to help friends build capacity and capability. And I think, you know, increasing what we're seeing is a much more sophisticated leadership coming out from many different countries. And each place I've certainly worked in has very much decided where they want to develop their different models. And it's quite interesting because they're very different. My friends and colleagues in King Hussein Cancer Centre have a very different view from Tata Memorial, and they certainly have a hugely different view from the Aga Khan about what's needed and how to develop that. There are some generic aspects that are useful to bring, but otherwise there's no substitute for kind of working at the ground level on that. I think the overall problem here I see is that no one is fulfilling their commitments under the Recife Agreement for workforce. High-income countries are still asset stripping like crazy. Nurses, physiotherapists, doctors. And it's a really hard one because at the personal level, it's very hard to say to somebody, no, you're not leaving country X to come to country Y. And only the other day, for example, some of my colleagues were interviewing for fellowship posts in our hospital. The only applicants were from the Middle East and from Southeast Asia. Now, and what do you say to them? Sorry, you're really good. And by the way, you should be staying in your own country. So that's very patronizing in that way. And I guess I haven't in my own, I'm interested in other people's thoughts actually, I haven't in my own head worked out how you address this. Does that make sense? I mean, and I think the numbers are really, really stark at the moment because all high-income countries are seeing a huge deficit. And my real worry is we're going to continue to just absorb doctors from low middle income countries unless some sort of agreement is found which stabilizes the situation. That means training a lot more people and keeping the recruitment and the retentions in country in some manner.
Thank you. Any questions for Richard? So John, go ahead, please.
Yeah, Richard, that was a great talk and somewhat sobering. I wanted to ask you about the WHO and this whole thing about the movement. Obviously, there's a resource question there. So what can they do to lobby to increase resources for these people? And Lisa sent me some statistics yesterday. Pfizer next year in sales will gain $82 billion. So how do you see that politically, and working with somebody like the WHO, that we can make things more equitable?
Yes, the WHO is between, I often find, a rock and a hard place on this. Colleagues like Andrea Barway, Bente Mikkelsen, who runs the NCD division, on one, they're servants of the states, of who they, of the individual member states. And I think there's some specific areas that they've done really exceptional work. So the World Childhood Cancer, the St. Jude's WHO Childhood Cancer Initiative has mobilized enormous funds for global childhood cancers. I think a lot of funds have been mobilized for elimination of cancer of the cervix, to be honest. When you look at the number of actors in this and the people that are being brought in, I'll be interested to see with Ben Anderson's move to WHO how the focus on breast cancer changes and how much more mobilization. Breast cancer is actually, globally speaking, a pretty well-funded domain when it comes to site-specific global cancers. But then there's everything else. And I guess your question really comes into the question is, how much power does the WHO have to leverage public good funding for individual countries? But also, I'm going to be blunt with you about holding individual countries to account with their own funding. Constantly bugs me that we talk about weakness in particular countries. And then when you look at the expenditure, government expenditure of healthcare as a percentage of GDP, it's 1%, 2%. Now, that's not the WHO's problem. That is country X's problem. A lot of these are political choices at individual country level. And I don't think we've been very good about calling this out. There's always this idea we're going to do quiet diplomacy. I don't know how long you can do quiet diplomacy and just accept that. But on the other hand, as an outsider to a country, I'm not going to mention particular countries here, coming into a country and saying, I don't get it. The reason things don't work here is you're not spending enough money on public sector healthcare is quite a difficult thing. So I guess, John, to say is the WHO can only go so far, but there are other levers and mechanisms for creating that. And I personally think World Bank, the IMF, the development banks, the Islamic Development Bank, the African Development Banks have a lot more power in this area with getting countries to actually put money in to improve cancer outcomes and health outcomes than the WHO do. So I think we're maybe looking at the wrong group of people, if that makes sense. We should be talking to the IDB and the AFB and people like that. That's just my personal opinion.
Talking to the money.
Talking to the money. It really is.
Yeah.
Money and politics.
They should take some of that from Pfizer.
I just think it would be, it's just a temporary measure. I think even taking money from pharmaceutical companies would only be a temporary measure. It still comes about building bottom up.
Yeah.
Thank you. We had a question from Grace and then Ian.
Hello, thank you so much for your talk. Just a little bit of background. I'm not usually a great fan of people saying what their PhDs were a decade ago, but I hope you will forgive me in this specific case. So my PhD was from LSHTM, and it was entitled something akin to a policy analysis of emerging infectious diseases and biological warfare in an international context. So please forgive me for actually bothering you with that. But the point is that in it 10 years ago, yeah, I sort of talked about the problem of responding to the previous emergency, right? So people always come up with whatever the right thing would have been for the previous emergency. So I think, I was certainly nodding along and clapping with a lot of what you were saying about like, don't fixate on one type of problem in a health system. It just is incredibly counterproductive. But I guess my question to you is how would you suggest that people not fixate on this type of infectious disease, given that I agree with you, we're going to see a lot of pandemics of various descriptions. How would you strengthen health systems so they can deal with both communicable and non-communicable diseases? Both the infectious diseases that are likely to happen, whatever they look like, whether they're, whatever kind of virus they are, while also strengthening healthcare systems. I mean, I agree with you that surveillance is incredibly important. The conclusion I came to was the need for rich countries to strengthen the surveillance systems in poor countries, because obviously I had an infectious disease bent, but I just wondered what your thoughts were sort of, now that
No, I totally look. I'm not going to throw GHS away, because the reality is, I think with the GHS planning in my other world, I keep saying to people, you've got to focus on this idea of genericization of what we call disease X and scenario plan around that. And there's lots of ways of scenario planning around that, because the problem with COVID-19 is people just will assume that the next pathogen will have the same sort of CFR, it'll have the same transmission kinetics, etc. You know, I was involved in MERS, and that was bloody frightening. That was a 35% CFR. 82% of people who got MERS ended up in ITU. Fortunately, you had to have a camel cough in your face directly to guess it. And, you know, obviously we don't go near camels. So it was, but the problem is that there's going to be a real politique, which is, you know, a disease X scenario still frightens the hell out of everybody, and people will still plan hard for that. But you hit the nail on the head. Number one thing is health information. And I mean health information from the public sector into the hospital side, and building the capacity up in those countries. Still, we've talked about this, what, for 20 years, probably 25 years? And it's glacial, the progress we've made in this. And I think on top of it, it does come down to this problem of professionalization of the workforce and the public, you know, the public health aspects of individual countries. And again, without sort of getting too far away from cancer, building up that healthcare workforce and ensuring the health information systems are actually built in. And again, a lot of this isn't rocket science. The problem is there's been a tendency to hand lots of money over to individual countries in ways which are fragmented, disconnected, and not properly aligned. And I'm, you know, there's plenty of publications showing shocking levels of money going in, tripping over each other because of what they're funding. So there's been a real failure around the planning aspects here, even taking into account the competency of some countries to plan their own health systems. Does that make sense? The political elites in some countries simply haven't got the experience and insight to do that. And that has to be built up as well. But you're spot on with I mean, your diagnosis all those years ago in your PhD still holds true today.
I just wondered whether anything had sort of improved since then, but now
I mean, if you had Ark here, if Partha was here talking, or, you know, Freddie Bray, he'd say there's been marginal improvements in some countries, but that's a 10% improvement.
Great, thank you, Grace, for your question. See, if you didn't go to NICE and you stayed after the PhD on the subject, things would have improved.
Well, you know, I always tell everybody I would have made exactly the same mistakes that the UK government did, but anyway, that's fine.
So Ian, you're next, and after that, I'm Pierre.
So great. So Richard, a great talk as usual, and equally depressing as usual. I wonder if there are any models for things that have worked better. I guess the one that springs to mind is AIDS and HIV, which, you know, despite all the problems that you've outlined, there has been reasonable success in getting antiretroviral drugs to the population and markedly improving the outcome. Now, it's easier with drugs than radiation machine or training surgeons and all the other things that you mentioned that we need. But is there anything we could learn from that effort that might work in terms of improving outcomes of cancer?
Yeah, thank you. I think the answer is yes, there are some elements, but I'm going to say something. I'm going to go right back to that first slide of mine, which is I'm increasingly convinced now that cancer is a reflection of our health systems. It is per se. The levels of you know, general medicine, pathology, etc. What we're really doing when we're looking at cancer is actually looking at the health system of the country. And I guess it comes down to this question is what countries have gone from being pretty mediocre to doing pretty well around the world. And I don't remember, it was years ago when there was that good health outcomes for low cost movement came around. There are a number of these examples around the world. And I mean, you know, sub-Saharan Africa, the Rwanda is held up as being, you know, the great poster child for this. Now, you know, if you put aside the political elements of Rwanda and the issues there, what made Rwanda a success? And the one magic ingredient that came in to begin with was the leadership and the political will to do something about this. Now, it's not to say, I think there are countries where the leadership can come from the cancer, the level of the meso level, the cancer center level, and from the advocates. It's just we don't have very many good examples of that, and particularly where you're having these sort of complex development of your health system. So I think short answer is yeah, but I'm going to be honest with you, Ian, I don't think we're very good about learning lessons. I think there's lots of fantastic papers on this. As you know, our view in health services research, implementation science research, it's really poor, actually, the level of this. There's, in terms of cancer control, and I think a lot more ought to be done in that particular area.
Thank you, Richard. So Anne-Pierre, please.
So yeah, thank you for your talk. It's been actually, I have to say, depressing, but certainly very informative. I have some question around patient advocacy in cancer. And I was just wondering, so how do you see patient engagement and advocacy on access to care evolve in this recently shaped landscape, in this pandemic? And what would you recommend to patient advocates? Sort of tips of, in terms of accessing good care, in navigating, this evolving landscape. So that'd be really insightful.
Thanks. Maybe just the individual patient level. One of the things I've been impressed by, maybe this is development of technology, is number of countries now. And I first saw it in India many years ago called Navya, which was like a second opinion public service that Tata Memorial and NCG put out. Those are developing around the world now, where like-minded public sector, publicly minded clinicians, senior people at a very high level, have been using technology to provide a free service to help patients navigate what are often very complex pathways, for which it's very easy to go down the wrong road, so to speak. So, if a doctor says you need X, they can double check whether they really do need X. That can be a matter of life and death, but that can also be a matter of financial catastrophe or not. So I think that's been a real boon, and I'd be surprised if that doesn't really expand post-pandemic because of the technological advances we've seen. More broadly on the patient advocacy side, it's more than critical. Political change is often driven by patient advocacy. But when you look at individual countries and regions, the level of patient advocacy and the power they hold varies enormously. And I think I've been impressed just talking to colleagues of mine in South Africa and Zambia recently, because I think we've also seen during the pandemic growths of suddenly all these patient groups as they've talked more on the internet. There's just been more engagement, and that sort of solidarity is really important, but also making sure that they're funded as organizations, that they have access to the right sort of training and information to advocate for the right things. If you have, just advocacy for immuno-oncology, we might be in a bit of trouble globally. There has to be a balance here in terms of what are you advocating for? But I think there's huge scope for that. And I would be surprised if that doesn't absolutely blossom over the next 10 years, because in a way, the economic contractions are going to force people's hands to start getting smarter, to start seeking better care, to start asking the hard questions.
Do you mean as in not, as you mentioned earlier, just not focusing on access to cancer care, but access to good care, just in
Correct.
general, stop just thinking in terms of disease, but like a specific disease or therapeutic area, but just, have a more like integrated approach into advocacy to care, just full stop.
Yeah, I think just a more integrated approach. I think you're always going to get the advocates for for instance, the breast cancer community, the site-specific advocates. I guess it's going to be the growth of advocates for the greater good, for cancer care per se, which I think will be the interesting part. But I'm going to be honest with you, I think it's horses for courses. There's some breast cancer groups that have been amazingly strong in also advocating for cancer more generally, because it comes down to power as well, how much power they have to influence politicians, other friends, etc. And these are by and large the elites in the country that do this.
But the larger patient organization are the ones that can actually, they have traction, and small, like in rare disease, in precision oncology, small patient organizations don't have, they're like volunteers, they don't have the resources, they can't do that. So they really have to sort of tag along large organizations that bang the drum, focusing a lot on their own sort of cancer site, but if it benefits the community at large. So it's relying on large organizations to have a more integrated approach.
Agreed.
Thank you.
Thank you. Lydian, your turn, please. You're muted.
Thank you. Well, I also would like to come back, Richard, on your slide, on your first slide, and also on the idea of advocacy. So when you say that precision oncology was really the flag, where the golden grail that should be on the top, I'm not 100% sure. So I wonder that tendency that, the best, the most advanced and high-tech oncology treatment is per definition the best ones. I'm not fully aligned with that. And I think what I feel now with the whole trend in Europe, especially, and the strong push from patients and industry about equal access for all European countries and abroad, equal access, is that what we really want? Because for expensive treatments, we discussed that, I think CAR T cells are now proposed for the list of essential medicines, and honestly, I'm glad it wasn't directly accepted. Shouldn't we look, remember, ground shot versus moonshot? Shouldn't we look at what is really best treatment for the patient and not push for every high-tech treatment, or certainly not medicines? Shouldn't we look at really prioritizing for those treatments and medicines that really bring benefit for the patient, as defined by the WHO, at least 6 months longer overall survival and quality of life? Because what I'm really afraid of is that big push now from industry that all those new high-tech and precision medicines, which not necessarily will give better overall survival, but will cost a lot more. But we have to evaluate, I think. We really have to look at what is the real added value and then prioritize for equal access. Also for India, we have been discussing Herceptin in India. I'm a HER2 patient, so I know what I'm talking about. Why do we need 1 year treatment? 3 months could be enough, and that could solve quite already part of the expenses, but nobody is willing to do the proper clinical trial to evaluate that. There were projects like that on the table with Tata Memorial, but we couldn't get it funded. I mean, the people who proposed it was not us, couldn't get it funded. So can't we not do more concrete things on that level?
What's interesting, I wouldn't mind actually Ian's views on something on the minute, because I think, as you've heard me say before, Liddy, that, we have to really, I think here's the challenge here. We kind of know what works. So, there's a paper that came out recently that Chris Booth did on the essential medicines list. We kind of know what works in terms of, if you're going to add things on to a particular basic package of care in any particular setting, if you don't get the fundamentals right, if you don't have an R0 resection, you don't get your radiotherapy, the diagnosis isn't correct in the first moment, there is no point getting medicine, X. What happens is in a lot of systems is all of this breaks down. And more importantly, what happens is people then believe that, for instance, now, I saw some work recently done from colleagues in the Middle East, which was extraordinary. People moving incredible distances out of Iraq, places, trying to seek immuno-oncology drugs because they think it'll cure their cancer. So there's a real disjunction moment between what people think in different countries is going to save them and the reality of what will save them. And so there's a kind of idea that everyone is super rational and human beings are super rational operators, and it's just not true. So there's a complete disconnect where this is concerned. I think you're right on the aspect which you said, I think, numerous times, which is we've got to get somehow inculcated the idea of basic packages, and somehow those basic packages have to be affordable in those particular contexts in particular countries. Because I agree with you, that's an absolute must. The other aspect I think comes down to the research piece, and I wouldn't mind Ian commenting on this again. I was really disappointed in the way that Persephone trial, which was the short course, you know, Herceptin, was just, I think, was blown out of the water by the French, who simply said, we don't believe it. So there's a real, what I would call, anti-reductive approach things. If you're saying to people, we want to dose de-escalate, we want to do trials where we give less, where we do less, where it's going to cost less, somehow you're not doing real cancer research. You're not doing cutting edge, innovative research. And I just find it a really disappointing in the research ecosystems we live in, that isn't considered as important as putting a new molecular entity first into man. But apparently it's not. And there's a real attitude issue, I think, with our research ecosystems on this. And the only research will prove that, you know, you don't need to do this. You can have, I think the recently was the dose holidays, wasn't it, for some of the renal drugs. You probably can do a lot better with a lot less, but you have to do the research to prove it. And I'm afraid a lot of research funders don't find this a sexy area to fund. Ian, any thoughts on this?
Yes, I mean, you're absolutely right. And I think we really should relook at what we mean by cost effectiveness. Now, the problem is that for many of these, if we're thinking of drug therapy, you know, and ultimately that's not even the best place to put it, but if we, you know, accept that there are some drugs out there that are fairly effective, including immuno-oncology for some diseases, they're totally inaccessible for the world's population. There's good evidence that for many of them, 1/10 of the dose, at least in the earlier trials, would be giving, you know, similar outcomes on small number of patients. Now, can you say that's equal to the approved dose? No. But I think we need to look at cost effectiveness in terms of cost access. So if we gave everybody in a lower or middle income country 1/10 of the dose of an effective agent, and it was almost as effective, but we increased, say, access by 5-fold, even if it was half as effective, we'd have multiplied the benefit by a factor of 2.5 times. And I think actually the evidence is that they're very close in efficacy. We're never going to do the large non-inferiority trials to prove that. But I think having a movement to, you know, and of course the companies will advertise against this, and the rich will get what they get in the West. But if we say gave everybody 1/10 of the dose, then I think we'd have a lot of effect with Herceptin. I mean, as you say, Persephone, I mean, the differences in those trials were absolutely minuscule for, you know, so 6 months of Herceptin with a Herceptin biosimilar already reduces the cost by a factor of 4. And probably you can do less. So, you know, the finished trials of 9 weeks. So there's a lot of room for using drugs differently in these countries and getting the practitioners to actually accept them. Using abiraterone with food, you know, a quarter dose. And with a colleague in India, we showed, I think that was a saving to the Indian Health Service of approximately $180 million a year. Just, and there's good evidence of equal efficacy. So there are things we can do. But I mean, it doesn't hit to the basic problem, Richard, that you outlined, that really, you know, these are still pretty peripheral benefits to, you know, training the surgeons, training the radiation oncologists, putting in the machines and so on. But every little bit, I guess, could help.
No, I agree. Thank you, Ian. And I guess as well, you know, I hate to point a finger all the time at pharmaceuticals, because in my particular neck of the woods, minimally invasive surgery, robotics. I mean, it's outrageous the speed in which robots are just being pushed onto systems with tiny evidence base. I mean, actually, to be blunt, at least pharmaceuticals is relatively well regulated in comparison. And actually, that's the problem. What people don't realize is this is a cost impact across the whole spectrum of the model of care, from more expensive multiplex diagnostics, imaging becoming more expensive, the surgery with bigger robots and more expensive, you know, all of this comes together as a package. And I understand why the big funders, the donors, the bilateral donors, the IMFs go, you've got to be joking. One cancer patient or 5,000 women with reproductive issues. I mean, it's not a rocket science if that's the offering you're making here. So until you drive down those costs, until you find something where, to be blunt with you, the economic equation makes sense, I think we're just going to get constantly pushed back on this. We were even talking about, you know, DNA vaccines for cervical cancer recently. I mean, you know, they're really expensive. I mean, they work, but my word, $40? Yeah. But there are solutions, and I think there are, you know, this is the problem. I think there are solutions to a lot of this. It is known. It is about that problem of the policy, the implementation, the scale up, etc. It's that end of the equation rather than this end of the equation.
That's very good discussion, and I have a question, because obviously there's a lot of coverage of how much let's say Gates does in the developing world, Global Fund, vaccination programs. There looks like they're doing stuff, but we had this discussion at the Creek 3 years ago now, where exact same things were said. I mean, we need to invest in radiation oncology, we need to invest into surgery in developing countries. Do they hear these messages and this is somewhere at the bottom of the list, or the messages never get to them? Why there is not enough investment? Because I don't think money is the problem. Looks like the world has way too much money. We're going into space so frequently now. It's like we don't go to Africa because obviously you need a COVID test for that. You don't need that to go to space. So, I mean, what is going on with the priorities, Richard?
Oh my word. I was talking to somebody earlier, I won't mention name because I'm not sure. Anyway, it was about World Bank and IMF and what's pushing the buttons and what isn't pushing the buttons. And I think part of this is, and it's absolutely true, which is you have to provide evidence and continually provide evidence of what the issues are, and then with that evidence, what the solutions should be as well. And whilst we've been very good at providing evidence for, you know, within the context of clinical trials for new drugs or whatever, we've been very poor in providing the evidence for systems and services change. And it's a real gap here. And then within that, I include the political economy of cancer as well. And I'm talking about cost effectiveness. I mean, you know, which is poor anyway in oncology, but I'm talking about really proper macroeconomic studies. But you constantly have to keep doing the work in specific ecosystems to demonstrate what you want to do makes sense and is going to improve outcomes. And this lady said to me, she said, the cancer community just doesn't do that. We get it in TB, we get it in maternal health, we get it in reproductive health, but that sort of evidence at that end of things, we do not get continually from the cancer community. And it speaks to this problem of this deficit in the second translational gap between what we already know and what we're developing, and the ability of taking that and actually changing services and systems for the better, so you actually get affordable and equitable outcomes. And that seems to be the nub of the problem at the moment. And I look at it and think that makes sense, really. Even in high income countries like the UK, we're only really just started to use our national audits to try and influence national cancer control policy in the UK. And we're still barely scraping away at the surface. Most of the changes to our national planning is made on political whims or on what I call ex cathedra, you know, the great and the good sitting at the top saying, I think it should be like this in my experience, rather than on the evidence base. So I'm not saying we're getting it right even in the high income setting. So I think if something can be done along that, I think you get a lot further forward. King is saying recently I was working with, and I'm very impressed, you know, they're really taking all of this to heart, you know, increasing the amount of political economic analysis, increasing HTA, increasing analysis of their pathways of patients and their outcomes. I mean, it's a much smaller country to do this because they realize the writing's on the wall for funding. They don't make it more integrated, if they don't make their models of care more affordable, you know, socially it will fall apart.
Thank you. Any final questions for Richard?
Hi, Richard. I've got one.
Oh,
the systems. Hello, Richard. The systems and services and infrastructure that you're talking about. I think one of the key messages from the CRIC conference that Lisa alluded to 2 or 3 years ago as well as your talk and other talks, is that, first of all, there's a communication sort of ecosystem. I was going to call it breakdown, but I actually think it's a lack of connectedness and a lack of listening to other experts. There are very much, we use the word siloed aspects to this. But I also think that there must be a shortage of people that have got what I call the adequate systems and services recognition and training. So if you had to put together a 5-year, I don't want to come out with these cliche things, but a 5-year plan or a 10-year plan of what you think needs to be done to improve services, not just cancer, maybe at the grassroots end, but that would also filter through to cancer. What do you reckon those things would be?
What we're already doing, which is every medical oncologist, clinical oncologist, pharmacist, surgeon, patient advocate we can get our hands on, persuading them to either do short courses, master's degrees, you know, and the real high flyers go off and do PhD. So they really are working at that end of things. And it could be everything from, you know, political economy work, health services research, implementation side. It doesn't matter. They're thinking about this. I mean, even I've got one individual man doing a PhD in policy, and it's the same, I guess, with all our friends in other countries as well. It's if you're going to do some research, do you really want to go and work in a lab? Or would you rather go off and study health services and systems and how to make things better for your particular ecosystem or country? But it's getting people who are both, I think, practitioners to go across the disciplinary divide. And I think we've had a tendency to, you know, traditionally, my PhD, people think I have a PhD. My PhD was in cell signaling, in calmodulin and small GTPases. I'm a hardcore lab person. You know, I went off and did a master's degree at LSE to relearn stuff. And that's what you need. You need a cadre of people across the whole spectrum who are willing to go off and learn these other disciplines and then become the champions and the advocates in this area. And that's at every country and at each individual level. And that would capacity build real changes and people who can then take forward cancer control planning who've got that kind of expertise and that vision.
Thanks, Richard. And I guess that comment extends to the publishing industry, because after all, the likes of Nature Cancer or Nature Reviews Clinic, they wouldn't take something like that because they wouldn't consider it in their scope. So I think you have to have more open-mindedness, would you agree, about how we actually tackle these big problems and not just say, oh, that's for a general medical journal, or that's for a policy journal, or this is for a, do you see what I'm saying?
Yeah, and I think it's getting better. I'm be honest with you. I think even, I mean, traditional, I was talking to Chris Booth actually the other day, even, you know, the JCOs of this world are starting to wake up to health services research. You know, David Collingridge certainly has, and he's published an awful lot on this. The journals are starting to sort of realize that, you know, but I don't think the system as a whole is very recognizing of it. I mean, to be honest, in the hierarchy of power, you know, number one, medical oncology first in man, you know, everybody else goes down. And the truth is, and I'm not saying this being funny about my other colleagues about this, research funding organizations are lousy supporters in this area.
Yeah.
I talked recently some of them as a group, and they all, oh yeah, maybe we should start thinking about funding this area. And it's like, really?
Hello, yeah.
Come on, you know. But it takes time to get people to recognize it as a bona fide research area. And don't get me wrong, there's been a lot of rubbish and poor research in this area over the last few years, real amateur night of the Savoy stuff. And I don't, you know, the Ajay Agarwals and the Booths of this world are an elite Olympic group. There's also a lot of dross that's been published. So I get why people have had bad reputations, but that can improve.
Thank you.
Thank you. It sounds like we as a world have a lot of work to do. And Richard, you have the most work to do since you're champion.
I'm going out drinking now, so it's all right.
Thank you so much. We wish you safe travels. A really inspiring talk, really difficult to hear certain things, but I think it also is an inspiration for future generations in terms of where they should focus and how they can make this a better place for us. So I will see you in 2 weeks. We have quite an interesting talk coming up about problems with drug development and CNS, central nervous system. You know, this world is very, very tricky. Alzheimer's has been a good poster child for that. So look forward to seeing you. And once again, Richard, thank you so much.
No, pleasure. Thank you for having me. Love to see everybody. Great to see friends as well.
Bye.
Love to see you. Bye.
Thank you.
Bye, Lily.
Bye-bye.
Bye, Lisa.
Bye.
Bye-bye.
Thanks, Lisa.